The 5 key systems you absolutely must know: cardiovascular risk and optimization, pulmonary and renal management, surgical site infections, endocrine and coagulation, and finally, postoperative VTE prophylaxis. Section 1, cardiovascular risk and optimization. We start here because cardiovascular disease is actually one of the leading causes of death after non-cardiac surgery. Seriously, an MI post-op carries a staggering 15 to 25% hospital mortality rate. It's huge. So to figure out that risk ahead of time, we look to the Revised Cardiac Risk Index, or RCRI. You've got to commit these absolute high-yield criteria to memory. Notice the major factors here. Undergoing a high-risk surgery. Think intrathoracic, intraperitoneal, or major vascular procedures. Then we have patient history factors, things like ischemic heart disease, congestive heart failure, or cerebrovascular disease. And finally, don't miss these 2 metabolic flags: preoperative insulin therapy for diabetes and a preoperative serum creatinine greater than 2 milligrams per deciliter. Any one of these significantly bumps up the risk of a major adverse cardiac event, which we call MACE. Now, alongside the RCRI, we've got to assess functional status. We measure this in metabolic equivalents, or METs. Basically, 1 MET equals the resting oxygen consumption of an average 40-year-old male. Excellent functional capacity is over 10 METs. Think jumping rope or heavy labor. But what you really need to watch out for is poor functional capacity. That's defined as under 4 METs. We're talking about just sleeping, watching TV, or golfing with a cart. Sorry to all the avid golfers out there, but that just doesn't count as a workout. If a patient is under 4 METs, that is a major exam trigger. It tells us they have significantly elevated cardiac risk. And this brilliantly illustrates our preoperative cardiac workup algorithm. Trace the pathway with me here. If the patient has an elevated risk based on those clinical factors we just talked about, we immediately look at their functional capacity. If they have moderate or greater functional capacity, meaning 4 METs or more, like being able to easily climb a flight of stairs, we don't require any further testing. You just proceed to surgery. But if their capacity is poor, so less than 4 METs, or if it's unknown, and getting more data will actually change our perioperative care plan, well, that is when we pull the trigger on pharmacologic stress testing. Before we move on from the cardiovascular system, we literally have to talk about coronary stents, because the timeline differences here are an absolute game changer. If your patient recently had a bare metal stent placed, current guidelines require you to delay elective non-cardiac surgery for at least 6 weeks while they're on dual antiplatelet therapy. But if they have a drug-eluting stent, that delay jumps all the way to at least 12 months. It's a massive difference, and it's all about carefully balancing the risk of stent thrombosis against the risk of surgical bleeding. Section 2, pulmonary and renal management. When we talk about preoperative optimization here, the name of the game is volume and toilet. Let's rapidly run through the evidence-based pulmonary interventions. First up, incentive spirometry. It is highly effective for increasing lung volume and promoting pulmonary toilet. Second, keep in mind that antibiotics absolutely do not reduce non-infectious pulmonary complications. But honestly, the highest yield point here is about smoking. There used to be this heavily debated myth that quitting smoking just a few weeks before surgery might paradoxically increase pulmonary complications. Well, the evidence just doesn't support that. Current guidelines definitively state that all patients should be encouraged to stop smoking prior to surgery, completely regardless of the time frame. Moving over to the renal system. If a patient has chronic renal insufficiency and is actively on dialysis, they need to be dialyzed within 24 hours of their planned operation. But when it comes to preventing postoperative acute renal failure, or ARF, the absolute most important protective measure across the board is adequate hydration. Intravascular volume expansion is totally key. For example, if a patient is undergoing a study with radiocontrast dye, which we know spikes the incidence of renal failure, administering 1 to 2 liters of isotonic saline beforehand is the proven go-to protective measure. Section 3, surgical site infections. This is a heavily tested area, mainly because compliance with CDC and American College of Surgeons guidelines is so closely monitored. Let's look at the absolute non-negotiables on this prevention checklist. You really want to focus on modifiable factors here. Preoperative showering with chlorhexidine the night before and the morning of surgery is essential. If hair removal is necessary, you must use clippers. Never ever shave, because shaving creates tiny microabrasions that harbor bacteria. Also look at the metabolic control. All diabetic and hyperglycemic patients must receive tight perioperative glucose control. Specifically, you want to keep that blood glucose strictly under 180 milligrams per deciliter. Now, what's really interesting about this slide is how the location of the surgery completely dictates our antibiotic prophylaxis. For upper GI and hepatobiliary procedures, the likely pathogens are enteric gram-negative bacilli, right? So cefazolin is your standard recommendation. But contrast that with colorectal procedures or, say, an unperforated appendectomy. The minute you move to the lower GI tract, you absolutely must cover for anaerobes. Because of that, the guidelines shift to sulfoxetine, cefotatin, or a combination like cefazolin with metronidazole just to ensure you get that crucial anaerobic coverage. Section 4. Endocrine and coagulation. Patient safety in this section relies almost entirely on exact medication timing and strict bridging protocols. Preoperative diabetes management is all about dodging unrecognized hypo or hyperglycemia. We need to quickly contrast two very different patient types here. Patients with diet-controlled diabetes mellitus, pretty straightforward. They can be maintained safely with absolutely no food and no glucose infusion before surgery. But insulin-dependent diabetics are a completely different story. They require both insulin and glucose preoperatively to stave off ketosis and catabolism. If they are going in for major surgery, they should be given 1/2 of their normal morning insulin dose alongside a 5% dextrose IV infusion. Just as precise is our management of anticoagulation. Timing errors here lead straight to major thrombotic or bleeding complications. Let's walk through this precise bridging timeline for a patient on warfarin or Coumadin. Because warfarin's effect hangs around for days, it's normally withheld for 5 full days preoperatively. For high-risk patients, we bridge them with low molecular weight heparin. Now, that bridge must be stopped exactly 24 hours prior to surgery. Postoperatively, because Coumadin takes a few days to reach therapeutic levels, you typically resume it on post-op day 1 or 2, while continuing the heparin bridge until the INR is actually therapeutic. So who actually qualifies as high risk and demands that bridging therapy? Highlight the high-risk category in your mind right now. If a patient has any mechanical mitral valve prosthesis, they are high risk. If they've had a recent stroke or TIA within 3 months, or recent venous thromboembolism within the last 3 months, they are securely in that high-risk tier. You cannot simply take these patients off anticoagulation. They absolutely require a careful bridge. Section 5. Post-operative VTE prophylaxis. This is our final system, and remember, things like DVT and PE are highly preventable as long as you stratify the risk correctly. To prevent these complications, we constantly have to balance the risk of asymptomatic VTE against the risk of major surgical bleeding. For a patient with a moderate VTE risk, say around 3.0%, with an average bleeding risk, the standard recommendation is pharmacologic prophylaxis. That means low-dose unfractionated heparin or low molecular weight heparin, plus a mechanical prophylaxis like intermittent pneumatic compression. But look what happens if the bleeding risk is high. If they are at high risk for major bleeding consequences, we immediately drop the pharmacologic agents. You rely strictly on mechanical prophylaxis until that bleeding risk subsides enough to safely allow for medications. Okay, let's wrap up this rapid review with a little active recall pulled straight from the text's multiple-choice questions. For an elective operation, how many days prior to surgery should Coumadin be discontinued? Is it 3 days, 5 days, or 7 days? So the crucial point is 5 days. You must withhold warfarin for 5 days preoperatively to ensure the INR drops down to a safe level, below 1.5. And that wraps up our explainer on high-yield perioperative care.